Namaste. Good evening, everyone, and a very warm welcome to the fifth edition of our Journal Club. At the last count, I was told that we have around 1,500, 2,000 doctors who are attending this particular meeting. It is truly inspiring to see such a gathering of dedicated professionals who share a passion for advancing medical knowledge and patient care. Over the months, Journal Club, an academic venture of Lloyd Healthcare, has grown into a space for learning, collaboration, and innovation. Today's is the fifth edition of Journal Club. I'm sure today's session, under the august guidance of Dr. Philip Kalra, Dr. Soumitra Ray, Dr. Manoj Chawla, Dr. Manisha Sahai, will continue that tradition, bringing together expertise and fresh perspective to enrich our understanding. I'd also like to highlight that we now have a dedicated YouTube channel where you can access the past sessions, insightful discussions, and upcoming updates. Please do subscribe, share. It's a wonderful way to stay connected. Thank you once again for joining us. Let's make this fifth edition a memorable and impactful one. I request Mr. Himanshu to take over from me. Thank you once again. Namaste.
Thank you very much, Mahesh sir, and I thank you as well as the directors of Lloyd Healthcare for allowing us to do such kind of immensely important academic programs. And without much ado, I will just introduce the panel members of this important program. So once again, very good evening, everyone. We have August gathering of more than 2,000 doctors, and we have very eminent panel members from India joining. We have Dr. Manoj Chawla, who is the diabetologist from the City of Dreams, Mumbai. Dr. Chawla is the director and consultant diabetologist from the Lina Diabetes Care, and he's also the consulting diabetologist at PD Hinduja Hospital as well as the Raheja Fortis Hospital. Apart from that, he is also very active at Diabetes India, holding various positions right from organizing secretary to scientific co-chair to being the organizing chairman in 2025. He is also an academician. He is a visiting faculty at DY Patil Medical Sciences. Dr. Chawla has, to his credit, more than 30 publications in various international and national journals. He is also editor in various journals like IJCMD. The next panel member that we have today evening is Dr. Manisha Sahai, who is a nephrologist from the city of Pearls, Hyderabad. She is a professor and head of nephrology at Osmania Medical College, Hyderabad. She is a renowned academician with more than 290 publications to her credit. She is one of the sought after speaker, having delivered more than 3,500 guest lectures at national and international forums. She is also a meritorious student of medicine and in particular nephrology, having received more than 13 gold medals. She is a guide as well as examiner of DM and DNB students in nephrology. She has immensely contributed in various academic disciplines, whether it is a dialysis or it is a transplant. She is also a firm believer of empowering the women in the nephrology fraternity, and she serves as the president of Women in Nephrology, uh, the chapter of nephrology, and she is also editor of various journals like IJN as well as IJT. She has been holding various prestigious positions at various forums, academic bodies. The next panel member that we have is Dr. Soumitra Ray. Dr. Ray is a cardiologist from the city of Joy, Kolkata. Dr. Ray is a very senior cardiologist with more than 30 years of experience. He was a professor of cardiology at Vivekananda Institute of Medical Sciences. He is also Vice President of Cardiology Society of India. He is visiting cardiologist at many hospitals in Kolkata, whether Manipal or Woodland or Bellevue Clinic. He has been a meritorious student of Kolkata Medical College. He has, to his credit, more than 500 publications, including textbook chapters as well as the consensus statements. He is also an author and convener of many guidelines in cardiology and also a recipient of many national as well as international fellowships and prestigious awards. So now I invite Dr. Soumitra Ray to take forward the proceedings of today's August gathering, and I also request him to invite today's faculty, Dr. Kalra, and inviting him also for the presentation. So over to you, Dr. Ray.
Thank you. Thank you. Very good evening, Mr. Himanshu, thank you for the introduction. And many thanks to Professor Philip Kalra, who has joined from Manchester, UK, with us tonight, this evening, and Professor Shahai. And as we said, our the diabetologist and nephrologist from different parts of the of India. And we are expecting a huge gathering of delegates online for the simple reason that the subject matter today intrigues people, it attracts people. It's such an important thing, and we feel a bit uncomfortable in dealing these things. So we need to know more so that we are more confident in treating patients with CKM. So I hope at the end of next 45 minutes, when Dr. Kalra will finish his talk, we'll be in a better position to serve our patients with this kind of condition. So now, first thing first, my most privileged job is to introduce Professor Philip Kalra, who is MB, MB, Chair of MD, FRCP of nephrologist from UK. He's consultant nephrologist at Salford Royal Hospital, Northern Care Alliance from 95 till date. He's honorary professor of University of Manchester, visiting professor at Manchester Metropolitan University. He's director research and innovation of NCA NHS Foundation Trust. He's director Donald O'Donnell Renal Research Center. He's education-wise Cambridge University with distinction MB and B chair with MA, MD, MRCP and FRCP. Former academic vice president of UK Renal Association. Former chair of NIHR Renal Disorder Group and UK Kidney Research Consortium. More than 380 publications, peer-reviewed journals with H-index of 66, pretty high. 21 textbook chapters, author of 5 postgraduate textbooks, including essential revision notes for MRCP. I firmly believe many people have passed MRCP by dint of this book, because this is the most difficult subject, as I said. Lead investigator and contributor to major international RCTs like Astral, Coral, Ironman, pivotal trials. And he's a pioneer in the concept of cardio-renal medicine. And he was telling, even before rest of the world thought of there is a link between heart and kidney, he started a dedicated clinic and dedicated program with his similar-minded colleagues of renal, kidney, or nephro, cardio joint clinics and joint academic sessions 15, 20 years ago. So salute to you, Professor Kalra, and welcome to this part of the world, though virtually. So I request you to take over the stage and give your deliberation. After that, I will come back to my 2 most esteemed panelists and we'll take it forward for the rest of the evening. Thank you.
Thank you so much indeed. It's a real pleasure to be invited, and great to see you all, a great audience. So I'm going to share my screen. So first of all, it's a real honor to be invited to give this presentation. Thank you, and thanks, Dr. Ray, for the introduction. So just a little bit of my background on a personal level. So you'll know that the surname Kalra is Indian. So my father was from the Punjab and came over to the UK after the Second World War, actually. So in about 45, and just before partition. And so I've got cousins still in India. I've given quite a few lecture tours in India all around, so I like it very much. I was back for 2 weddings, family weddings in the last 2 years, actually, which were really exciting. I hadn't realized they go on for 3 days, but found that out. So, you know, so many lovely links with India. So family in Delhi and Uttar Pradesh, actually. So thank you very much. I've been a consultant specialist in nephrology for 30 years in Manchester, and I do quite a lot of work with my brother, who's a cardiologist as well. He works in the south of the country. So on to the topic then, newer therapies in optimizing the outcomes of CRM, so cardio-renal-metabolic disease. And this is my outline. I'll be saying a tiny bit about the definition and epidemiology of the cardio-renal-metabolic syndrome. And then the biggest challenge of all that was put to me by Himanshu was to look at the pathogenesis of this condition. And this has needed quite a lot of work by me in preparing this. It's in the early part of the talk, and some of it is quite highbrow and scientific, and I'll go fairly quickly through that because I don't want to put you all to sleep by it. But then later on in the talk, we get on to the meat of things that you'll be able to remember a lot more, which is, you know, the evidence base for treatments in the cardio-renal metabolic syndrome. Now we've got some drugs that, of course, work on several different organ systems in the body, not least the SGLT2 inhibitors and the GLP-1 receptor agonists. And there are more treatments on the way as well, as you all know. And I think one of the nicest ways to pull this together is to use a case, okay? Funnily enough, this chap has been named with my middle name. So I'm Philip A. Kalra. So Anil is my middle name. And this chap is Anil. So 69-year-old man. He's overweight. He is known to have diabetes, type 2 diabetes and hypertension. He's had a TIA. So you'd say he's had established cardiovascular disease. He had that 2 years earlier. He doesn't exercise at all because he works so hard. And we find this a lot in the UK. You know, I'm not saying with all of us, but there are some hardworking people, you know, have their own shop, etc., like that, 60 hours a week. And you can see his medications there. So metformin, linagliptin, gliclazide, irbesartan, half dose, amlodipine, and low dose atorvastatin. And he comes to his GP with exertional breathlessness. And then we can see that he's hypertensive. Look, if I take you over to this section, 158/88, even home monitoring, which I find to be very, very helpful. 152/90. He's got a normal hemoglobin. He's got a slightly high cholesterol, but his LDL cholesterol for someone who's had vascular disease is a bit high. We'd want that to be about 2.4 or even lower the millimoles per litre. And he's got kidney impairment already, this guy. He's got a GFR of 48 mils a minute. So, of course, for the non-nephrologist, you'll all know the scale of KDIGO, but this puts him into stage 3A CKD. He's also got significant albuminuria, and just forgive me, so these are the units we use. So if you use in India milligrams per gram, this will be 450 milligrams per gram. Okay, so very advanced albuminuria. We have this thing called the Q risk for cardiovascular risk prediction. 34% likelihood of having one in 10 years, according to our Q risk that the GPs use. Liver function, ALK, phos, and bilirubin normal, but ALT is higher than we would say is normal at 65. You can see that. And then his glucose is not really that well controlled, is it? The HbA1c of 71 millimoles per mole, that's going to be around 10 or 11% if you use percentage with HbA1c. So there's a case. He's got a lot going on, as you can see. He's overweight. He's possibly got some issues with cardiac dysfunction, more of that later on. He's got renal impairment with albuminuria. He may have early MASLD, which I'll define in a minute. His glucose control is not very good. He's hypertensive. So, and also he's got some lipid abnormalities. So loads going on in this CRM case. Right, so let me just give you a few definitions. I'm not going to read all this material out. I'll just choose some key bits for you. So yes, the cardio-renal-metabolic syndrome, some people have called it CARE-ME, haven't they, in the past, the cardiology, renal and metabolic. It's defined, the metabolic syndrome itself, which we've abbreviated here, METS, is defined by central obesity, poor glycemic control, poor lipid control and hypertension, and it's believed to affect up to a quarter of people adults in the world, which is amazing, isn't it? Amazing. So we're talking, what, a population of 8 billion. I presume 6 billion will be adults. So that's one heck of a lot of people. And the prevalence is rising in parallel with obesity and type 2 diabetes. And we know that the metabolic syndrome is associated with cardiovascular consequences. We know that it's an important determinant of CKD, and that is independent of diabetes or hypertension. I'll show you some data on that. And this is interesting. I pulled out this reference. In a study from the United States of over 500,000 type 2 diabetics, only 6% of them had isolated diabetes. Okay, the remainder had at least one of the following conditions, like hypertension, hyperlipidemia, coronary artery disease, CKD, CVA, peripheral vascular disease, atrial fibrillation, or heart failure or gout. And half of them had at least 3 or more of these conditions. So, these things segregate with, with type 2 diabetes segregates with these other CARE-ME conditions, if you like. So what about the pathophysiology? This is just an overall brief summary. I'm going to go into a bit more detail because I learned such a lot in looking at this pathogenesis. So the metabolic syndrome and CKD frequently coexist. They synergistically worsen each other to amplify the cardiovascular and kidney outcomes. Epidemiologic studies identify metabolic syndrome as an independent determinant of CKD. And then accelerating GFR decline, progressing towards end-stage kidney failure. And just, again, for the non-nephrologist, we class that as a GFR of less than 15 mils a minute, or the commencement of renal replacement therapy. And interestingly, it's an independent predictor of that, even after adjusting for diabetes and hypertension. So independently, it will lead to this kidney damage. And then that sort of shifts us away conceptually from, we've always had this hyperfiltration-centric model, the Brenner hypothesis, you might remember. And we're now thinking of other mechanisms, not just hemodynamic damage to the glomerulus, leading to a persistence of CKD and progression. And we're hearing now more about systemic insulin resistance, lipotoxicity, and this was a new thing for me altogether. I'll share with you, the generation of free fatty acids in metabolism, and also the importance of inflammation, and all of this disrupting cellular energy homeostasis. So as the driver of this condition. So here is a schema which one of my research fellows pulled together actually for a recent article, just showing the factors that are actually affecting the kidney. When he first showed me this picture, I thought he'd show me a picture of the liver here with a kidney stuck under it, but that's meant to be one kidney. So I think we need to straighten that up a bit, but never mind. But anyway, so we've got adipose tissue dysfunction. I'll come on to some of these individual parameters later. We've got liver dysfunction. We've got systemic insulin resistance. And I was really interested to see what that actually means. I mean, we hear a lot about insulin resistance, obviously in type 2 diabetes, but what does that actually mean in pathophysiology? Something that I was pleased to go and look at. And then there's looking at the kidney specifically, what is being damaged? The glomerular endothelium. So we're looking at the little blood vessels in the capillaries of the glomerulus being damaged in various ways, leading to albuminuria. Podocytes, that really important cell sitting on the outside of the glomerular capillary, proximal tubular cells, and leading to interstitial inflammation. And overall, there's some shared intracellular stress pathways, again, which I'm going to mention, particularly mitochondrial dysfunction leading to, reduction of energy, but also generation of reactive oxygen species. So carrying on, thinking of the kidney injury that's associated with metabolic syndrome, we know that it shares various endocrine and metabolic disturbances, central adiposity. We hear about this visceral obesity of people, insulin resistance, dyslipidemia, chronic low-grade inflammation, as well as the RAS activation, so renin-angiotensin-aldosterone, we call neurohormonal activation, and the cardiologists amongst us know that only too well. So we know that from pooled meta-analyses that 50 to 70% increased risk of developing CKD in people with metabolic syndrome. I've said that already, but that's consistent in different geographic regions across the world and different ethnic groups as well. Now, this was something I've hinted at before, that excess renal risk persists even after you adjust for diabetes and hypertension. So meaning that the kidney injury is it's not just caused by hyperglycemia or hemodynamic stress. Okay, other things are really, really important. Let's talk a bit more about that metabolic syndrome link. It often, in the early stages, presents with modest albuminuria before we get major reductions in GFR. And yet, even at that very early stage where you've just got low-grade albuminuria, there's still already a very high burden of cardiovascular disease at an early stage, out of proportion to the degree of loss of GFR, suggesting that the renal injury is initiated on the microvasculature and metabolically active cell populations rather than through losing whole nephrons. That's really interesting. And that then links with other broader cardiometabolic disease patterns where endothelial dysfunction and cellular metabolic stress precede overt organ damage in, for example, the heart or other tissues as well. And some of the things that amplify this kidney dysfunction are listed below. I'm going to go into more detail in short, but so we've talked about insulin resistance, dyslipidemia, and inflammation becoming a really big topic in all organ dysfunction. So liver, heart, brain, kidney, obviously, and yeah, I'll come on to these other things now. So this was something I wanted to look up. We've heard so much about insulin resistance. How does it actually lead to organ damage? Big question. So it's a defining feature of the metabolic syndrome associated with microalbuminuria and CKD. So experimental models show that insulin resistance drives, instead of glucose metabolism, of course, as glucose can't get into the cells, it drives enhanced adipose tissue lipolysis, so breaking down the fat, resulting in elevations of circulating free fatty acids, and they overwhelm the renal and other organ lipid handling and oxidative capacity of that organ. Each cell has an ability to deal with some free fatty acid metabolism, but this overwhelms it, and so it leads to damage. Okay, so in parallel with that, the insulin resistance induces an inflexibility of these cells characterized by an impaired ability of, for example, the kidney tubular cells to switch between glucose and fatty acid oxidation. They still like glucose, and they're impaired from switching over to fatty acid oxidation. So that leads to the mitochondria dysfunctioning and getting, so therefore, reduced energy in the cell, which will die, and also creating reactive oxygen species. So that's almost like a mechanism that could be going on in every tissue of the body with insulin resistance. Other things that happen with the high insulin levels, they exacerbate renal injury by increasing sympathetic nervous system activity, promoting sodium reabsorption. Of course, that relates to the SGLT2 inhibitors, and also stimulating the renin-angiotensin system. And of course, that triggers the inflammatory genome in the kidney, the NF-kappa B. It triggers oxidative stress and, of course, leads to damage in other organs, not least the heart. Adipose tissue, this center, the visceral fat that can lead to low-grade inflammation, which is the trigger to it all, right? We believe that in the metabolic syndrome, this increased adipose tissue, it undergoes hypertrophy. There is hypoxia there. There is fibrosis in that, the fat abdomen, and immune cell infiltration with macrophages, shifting the whole dynamic to a pro-inflammatory adipokine profile. So we see elevated leptin and pro-inflammatory cytokines. Interestingly, adiponectin, you'll have heard of, is almost like a protective cytokine, and that's reduced in this inflammatory milieu. And this is associated with increasing CKD prevalence and faster rates of progression. And then we need to mention hepatokines, so the liver dysfunction is particularly relevant in MASLD. So what's that metabolic dysfunction associated steatotic liver disease. Now that's what we used to call NASH, isn't it? So hepatosine dysregulation occurs, leading to immune activation, driving these inflammatory mediators that we all have heard of, like TNF-alpha, IL-6, which are directly damaging to various cellular tissues. Okay, now this is one last concept again that I didn't know anything about, and just pulling this talk together has taught me, is when we're looking at the hepatokines. We've all heard of, most of the nephrologists here will have heard of FGF23, fibroblast growth factor 23, which is made in bone cells, and this is really relevant in terms of phosphate excretion in the kidney, etc., etc. But now we're hearing about FGF21. This fibroblast growth factor 21 is a hepatokine, so made in the liver. It's a key endocrine mediator in all of this axis, the hepatic renal axis. We know that FGF21 levels rise in obesity, in insulin resistance, and in CKD, and it implies FGF21 resistance, which is interesting. Cohort studies show that high levels of FGF21 independently associate with bad kidney outcomes, accelerating GFR decline and kidney failure. And in experimental models, FGF21 seems to be protective. It improves insulin sensitivity. It enhances this fatty acid oxidation and suppresses inflammatory pathways, really importantly, mitigating lipotoxic injury to various tissues. There are one or two other hepatokines mentioned here, like phetuin A, things like ceramides, and so on. Okay, so to summarize, this is metabolic associated steatotic liver disease, MASLD. We all have heard about it. It incorporates a spectrum from simple steatosis through to steatohepatitis, where there's inflammation in the liver. Then we get advanced hepatic fibrosis, a bit like chronic active hepatitis, really. And then in the very late stages, we get cirrhosis, and it's a really common cause of cirrhosis now. We now believe that chronic liver disease prevalence, it accounts for about 25% of the world's chronic liver disease, this MASLD. For example, in a European population, it could be up to, there's some figures have said 44% in selected populations. And it's very common in diabetics, as you can see. At least a quarter of patients will have some degree of MASLD, even if it's the early steatosis. One or two points about this. Now, we've gone away from the highbrow pathophysiology, just looking at the presence and severity of MASLD in a large primary care cohort. So what they took here were patients who had just had abnormal liver function tests in primary care, and they went on to look at their fibrosis scores using a FibroScan. And look, this is really interesting in terms of the sensitivity of testings, because we don't routinely do gamma GT anymore. We do ALT, alkphos, and bilirubin, of course, albumin, but not gamma GT. And you can see that it was more prevalent and abnormal GGT was than the other blood tests for liver function tests. Anyway, in terms of the fibrosis scores, you can see that in this population of 1,200 patients, 57% had just low fibrosis or low parameters on the FibroScan. Something like 35% had intermediate, and 8% had high features in keeping with like a chronic active hepatitis with early fibrosis or cirrhosis. So just to give you an idea of that, okay? So we know that there's a complex interplay between MASLD and cardiovascular disease in metabolic syndrome. And we know that there is this crosstalk between type 2 diabetes, cardiovascular disease, adipose tissue, the gut and the liver. What's missing from this figure is, of course, the kidney, as I've just told you, because it's a really important target organ, and the damage that goes on in the kidney also contributes to the damage going on in this setup as well. And of course, we can get cardiac damage as a result of the metabolic associated MASLD with endothelial damage, left ventricular hypertrophy and fibrosis, and many changes in things like the hemostasis, coagulation factors, lipids, etc., etc. So I haven't got time to go into any more. Just to say that we ourselves had undertaken a study looking at MASLD. We've got a cohort in my hospital that I'm the CI for of 4,000 patients with non-dialysis chronic kidney disease, and one of my research fellows at the time, now a colleague actually, looked at this. Raj is I think from Kerala. We looked at all of the patients at the time, 3,000 patients, and looked at those who had had a scan, and the number that had complete data sets was 852, as you can see here. And of those, 138 had changes of MASLD, and the rest, 183 and 669 were normal. Now, don't go to sleep with this slider. This is, I'll just point out one or two things to you. I'm sorry it's very detailed, but these are the people here look with MASLD. These are the normals, but when I say normal, they've all got chronic kidney disease, by the way. But the things that are different look are these people, not surprisingly, have got a bigger BMI. They have more hypertension. They have more diabetes, 49% versus 30%. And they also have more usage of ACE or ARB, not surprisingly, because of who they are, the diabetes, etc., etc. Also, if we look at the blood tests, their ALT was higher, not surprisingly, but not very high, still in a normal range. Notice that. What else? Interestingly, their GFRs were lower their creatinines were lower and GFRs were better than the people who did not have NAFLD. Their gamma GTs were higher, and so their cholesterol metabolism was worse as well, not surprisingly. Okay, and this is the main outcome that came out of this paper, that when we looked at the difference between the two groups, normal or NAFLD, and we corrected for many parameters by doing a propensity score matching. So between the two, so they have the same age, they have the same GFR, etc., etc. And what we found, the main thing that came out, was that this was a risk factor for non-fatal cardiovascular events, as you can see. Non-fatal cardiovascular events. So that's the summary of that study. There it is in red at the bottom. So in our CKD population, not on dialysis, having MASLD was an increased trigger for non-fatal cardiovascular events. And if you look at the worldwide literature, this is a systematic review and meta-analysis of MASLD and cardiovascular disease. And you can see that all of these studies published, I know it's a long time ago, over 12 years ago, you can see that they all favor the fact that the MASLD is linked to cardiovascular disease. You've seen these forest plots before. So this is towards favoring cardiovascular disease. So that's the summary of the pathophysiology. So I won't go over that again, but just to point out the key topics: adipokine and hepatokine signaling, ectopic lipid accumulation, this lipid toxicity with these free fatty acids I didn't know anything about actually until I was reading about this reprogramming of the mitochondria, the oxidative stress and epigenetic remodeling of the glomerular cells and things, all contributing in this milieu affecting multiple organs. Right, and there's the summary. I've been through that already and mentioned many of those factors. So let's go on now in the last 20 minutes or so to talk about the potential treatments we've got at our disposal. There are several established treatments that confer kidney protection, but also protection to the heart and vasculature, as well as helping the metabolic syndrome and diabetes. So we've got renin-angiotensin system blockade. We've got now the non-steroidal mineralocorticoid receptor antagonists. You've heard of finerenone is available in type 2 diabetics. We've got the SGLT2 inhibitors and the GLP-1 agonists. And here's another schema from my research fellow, pulling together where these things can be of benefit for us and what they can do. Again, I won't read all of these things out, and I'll try and work through some of these things as we just go through the evidence. So let's first of all talk about renin-angiotensin-aldosterone system inhibition. I mean, this has been around with full recognition in renal disease for 24 years, since 2001, but more recently we've had the mineralocorticoid antagonists coming in to CKD. Clearly, we know these drugs have got anti-proteinuric and renal protective effects, and we know that part of that is hemodynamic. I'm going to show you that in a second, but also they have benefits by attenuating oxidative stress, by suppressing that inflammatory genome, the NF-kappa B, etc., by reducing fibrosis. We particularly are aware of that, and the cardiologists amongst us will know this, from left ventricular remodeling with use of these drugs, reducing the fibrosis in the heart and having, we believe, some beneficial effects on mitochondrial function. The latter is all really given credence by experimental models rather than direct human validation. One thing I'm going to get in very early now, really importantly, is this, and this, I use this slide all the time when teaching GPs, basically. So if we waited for a diagnosis of CKD with a GFR of less than 30 mils a minute, that's the blue line, look, for the diagnosis of CKD, and then start treatment, we will have lost something like 3/4 of the functioning mass of the kidney. We'll have lost three-quarters of the nephrons when we get to a GFR of 60. That tells us that, when we are very healthy, we've got a lot of functioning renal reserve that we don't use. So to get to a GFR of less than 60, it means you lose all of that, and you lose other tissue as well. However, if we start acting when the urine ACR is 3 in UK milligrams per millimole, that's it, maybe in your money 30 milligrams per gram. If we start acting then when it becomes abnormal, then we've only lost about 25% of the functioning mass. That's a really key point, and it's honestly, I make this message all the time wherever I'm speaking. We act early. Now, back to ACE inhibitors and ARBs. These were studies that many of you will remember from 2001. Type 2 diabetic patients with kidney disease, average GFR around 60 with a gram of proteinuria a day. And both Renal's study with losartan and the IDNT study with irbesartan showed that there was a big, 20% benefit in reduction in the endpoint of doubling of creatinine, which is roughly a reduction of GFR of about 56%, end-stage kidney failure or death. Okay, so as a result of that, we in nephrology got really excited and started using these drugs in every single CKD group that we came across. And okay, we then more recently have the effects of finerenone. So in the Fidelio study, this is a diabetic kidney disease study where people were on maximum tolerated ACE and ARB. They were then given either placebo or this mineralocorticoid antagonist, a bit like spironolactone, finerenone, that causes less hyperkalemia than spironolactone. You can see it's 5,500 patients, and there's the key composite outcome. And it made a difference. Okay, so we are now using finerenone in people with type 2 diabetic kidney disease who are progressing and they've got proteinuria. So I just wanted to show you this, just a quick, nice schema that I had produced some years ago, just showing you how, just to remind you how renin-angiotensin blockade works in the kidney. So here's a kidney. We've got 1 million glomeruli per kidney. I'm not showing them all, but we've got CKD, so we lose substantial number of these gloms. And what actually happens in the remaining ones? Well, there's hypertension going on, and we have the release of renin from the damaged glomeruli. Renin, of course, stimulates formation of angiotensin 1, which is not biologically active. Angiotensin 1 is converted to angiotensin 2 in the lung capillaries under the influence of the ACE enzyme. We all know all of that, of course. So what does that do? So angiotensin 2 directly stimulates the efferent arteriole, causing constriction. So that increases the pressure in the glomerulus, that hyperfiltration injury I mentioned earlier. But also it leads to an increased systemic pressure, and it leads to the release of aldosterone from the zona glomerulosa of the adrenal gland. And these two molecules together stimulate fibrosis in the heart and the kidney. They're pro-fibrotic molecules. We see in the normal situation a little dribble of proteinuria coming out of the capillaries down into the renal tubule. We can handle that nicely. But in this high pressure system, we have much higher levels of proteinuria due to the hyperfiltration taken up by the tubular cells, overwhelming the tubular cells, leading to apoptosis and death. And now we obviously block all of that with ACE inhibitors, ARBs, and with finerenone. So what about SGLT2 inhibitors? Of course, these are the new kids on the block. They've been around in diabetes for well over 10 years, but then we've now got established evidence in clinical models that they're of benefit in renal specific trials and in cardiac specific trials, as well as do you remember the old CVOTs, we called them, the cardiovascular outcome trials that the FDA now demand but for any new anti-diabetic treatment that comes along? Now, in those early CVOTs, so with, do you remember canagliflozin, the CANVAS program, empagliflozin, EMPA-REG, and then the TIMI program, which is dapagliflozin. All of them as secondary endpoints looked at kidney endpoints, secondary endpoints. Obviously, the main endpoints of a CVOT is, cardiovascular events and death, of course, but the renal events all pointed in the same direction. Look, the reduction in GFR of 40%, end-stage kidney failure or death. Look at them, all to the almost like a 50% reduction of those events, mainly driven by this decline in GFR, not end-stage kidney failure, because there weren't many people with really low GFRs going into these CVOTs. And as a result of that, we've had some renal-specific trials. So the first one of these was Credence, the canagliflozin study, published in 2019 in Melbourne at the ISN. I was there. And this basically took people on maximum tolerated renin-angiotensin blockade, ACE inhibitor or ARB, and gave them either canagliflozin at low dose 100 or placebo. And the primary outcome was cardiovascular death, renal failure, or decline in kidney function, as you can see here, doubling of creatinine. And this is what happened. I remember when this was published we don't get many positive trials in renal medicine, and the whole audience stood up and applauded as the blue line appeared in the audience. So there was a 30% reduction in this kidney outcome. So this was the first kidney-specific trial with SGLT2 inhibitors. and you can see that the hazard ratio is 30% reduction of that endpoint and a high p-value. But notice that there was only a minimal change in the HbA1c, just the percentage down by about 0.5, so that's 4 millimoles per mole of HbA1c, so it was not due to a lowering of glucose. And then, of course, we've had the DAPA-CKD trial, many of you will know, in which there were 2/3 of the patients had type 2 diabetes and CKD, but 1/3 actually had no diabetes. Really new for us, and this has absolutely changed practice in nephrology. So all these people had GFRs of 25 to 45, significant albuminuria. You can see that's, again, 220 to 5,500 milligrams per gram, and similar outcome. And you can see outcome primary composite. You can see declining kidney function, end-stage renal failure or death, and the hazard ratio down by almost 40% with that's dapagliflozin. And you can see also those without type 2 diabetes, these are non-diabetic CKD patients, 50% decline in that primary outcome. And this is the cardiovascular and heart failure events. Just 1 or 2 points about the use of these SGLT2 inhibitors. We do see this initial drop in GFR, a bit like you see with an ACE inhibitor or ARB, followed by a slowing of the decline of GFR over time. Whereas in the placebo group, they're racing away at 3 mils a minute or more loss of GFR per year. So it's almost like short-term pain at the beginning for long-term gain we talk about in CKD. And what's the mechanism of action? Well, you can see that the SGLT2 channels are in, it's a transporter system in the proximal tubule. It reabsorbs sodium and glucose together in the proximal tubule. And what happens with the SGLT2 inhibitor is it blocks that absorption. So glucose and sodium appear in the urine at much greater concentrations. They go round to the distal tubule where you remember the macula densa senses the sodium, and it stimulates release of adenosine, which constricts the afferent arteriole, so reducing the pressure in the glomerulus. So taken together, RAS blockade reduces the pressure in the glomerulus by dilating the efferent arteriole. SGLT2 inhibitors reduce the flow in, and so you've got this enhanced hyperfiltration protection. And then what about heart failure? Well, we know that these drugs are now very, very valuable, and we've had heart failure specific trials like DAPA-HF. John McMurray is a cardiologist in Glasgow in the UK, and you can see that just like in the kidney specific trials, we've got heart failure specific trials which show that drugs like DAPA or empagliflozin are excellent in terms of reducing the primary composite of worsening heart failure, admissions for heart failure, or death from a cardiovascular cause, okay, on their own. So these drugs are just used in widespread fashion. This is an interesting slide that shows, again, back to my point about testing the ACR and starting early. In people, if you start empagliflozin in patients with an eGFR of 20, they predict your benefit by shaving just 1 year off the dialysis, time to dialysis. But if you start when the GFR is 60, then you'll shave 17 years off. Which is brilliant. If you manage to start much earlier, then you could shave 26 years off. You can, in other words, delay the need for dialysis by 26 years. Obviously, what it doesn't tell you is along the way, these people would be at risk of having cardiovascular events and death. But that's just looking at the end-stage kidney failure risk. What about GLP-1 receptor agonists? We know in kidney disease, we now, as well as obviously they're used for obesity, they're really good in diabetes, they're very good hypoglycemic agents. Well, we've got now renal specific studies. There was one called the FLOW trial, which was published at our European Kidney Meeting in Stockholm in 2024, really showing a major benefit of semaglutide in type 2 diabetic kidney disease. And people then ask the question, well, hang on a minute, we've now got the SGLT2 inhibitors. What about both? So in this trial, there were very few patients with SGLT2 inhibitors. So people have gone on to look at that combination and shown that there's an added benefit in the patients who are on both an SGLT2 inhibitor and GLP-1 agonist. This is a recent study from something called the SELECT population, which were obese patients being treated with semaglutide, and I won't go into all the data, but it basically shows that in the subgroup with heart failure, of which it was about 25% of 17,000 patients, so about 4,500 patients, that there were major benefits in semaglutide, in reducing the outcomes of patients with heart failure and obesity. Just to say that now, if you look at the American Diabetes Association from this year, there's a recommendation that these drugs, the SGLT2 inhibitors and the GLP-1 agonists, have a really predominant place at the beginning of the treatment pathway for people who've already got cardiovascular disease, those with a high likelihood of cardiovascular disease, those with heart failure, and those with CKD. They're now pushed to the top of the treatment algorithm for these patients. Really important, and definitely using both together. Okay, so there are some new treatments coming in along the line. I'm not going to dwell on this because I know I'm at about 40 minutes. I've got 5 minutes left, really. So there are actually FGF21 analogues being developed. So remember, I said that in MASLD, FGF21 looks as though it's a beneficial cytokine, or beneficial hormone, I should say. And so there are analogues coming in that might be beneficial for hepatic steatosis and treating MASLD. Right, we mustn't forget treating cholesterol, of course. This was a renal specific trial called SHARP, which showed that there was a major benefit to kidney disease patients in terms of heart attacks and strokes with this. That was an old study. And this is just the overview of the CRM management. I won't dwell on that in the interest of time. Right, last 2 or 3 slides. Let's talk about Anil. You can see that I chose my middle name for this guy. Remember, he's got a lot going wrong with him, with his MASLD. He presents with, exertion-related breathlessness. He's got CRM with hypertension. He's overweight. He doesn't take any exercise. He's not on the right drugs. He's got a bad lipid profile. He's got CKD, stage 3A CKD with albuminuria. He may have MASLD. He's got a high cardiovascular risk. He's got poor glycemic control. And his echo, I didn't tell you this before, showed that he got a left ventricular ejection fraction of 56%, which is quite good. But he'd got increased filling pressures and diastolic dysfunction. So this guy has got HFpEF, heart failure with preserved ejection fraction. So how do we holistically care for this guy? How do we optimally manage his cardiovascular renal metabolic syndrome? We should be thinking about, he should lose weight, shouldn't he? We should get good blood pressure control, 130/80. We should get better glycemic control. That's an HbA1c of less than 55 millimoles per mole. So I think we're looking at something like 7.5% or less, aren't we? His lipid management, do you remember he's had a TIA, so he should be aiming for an LDL cholesterol of 1.8 or less. We should reduce his CKD progression by reducing albuminuria. We do that with SGLT2 inhibitors, with ACE inhibitors or ARB, and now with the GLP-1 agonists. We reduce his cardiovascular risk and reduce inflammation by giving those treatments. What about his HFpEF? We can talk about that. He might have MASLD as well. And these are the treatments at our disposal. As I've said, RAS inhibitors, ACE, ARB, non-steroidal MRA, if he's he is diabetic, SGLT2 inhibitors, GLP receptor agonists, or now triple incretins like tirzepatide or Mounjaro, statins, even going to inclisiran and the PCSK9 inhibitors. antiplatelet therapy and IM. So this is the last slide. You'll be very pleased to know. So this is my suggestion for his treatment, really, over to the left. All the data is the same there, but I think, first of all, personally, and I'd love to hear what the diabetologists think. 5 years ago, the only anti-diabetic drug that I was happy enough to prescribe was glycoside. Now it's the last thing I would prescribe, and I'd be very interested in your views. Yes, it reduces glucose very well, but it leads to hypoglycemia, and we're well aware of the dangers of hypoglycemia in the middle of night of the diabetic patients, sudden death in the night, sudden cardiac death. And they gain weight as well, don't they, the sulfonylureas? So I would stop that, but I'd also very much change a lot of his other profile look. So I personally would want to improve this blood pressure, 130/80. So I would increase the irbesartan to 300. There's the BP target. It certainly increases that atorvastatin to 20 to 40 milligrams per day. We want this LDL cholesterol down to 1.8. He's had that. He's got vascular disease already early. And then I would bring in one of these SGLT2 inhibitors that's got evidence, dapagliflozin or EMPA, aiming for an HbA1c of 55 or less. And then he's overweight. Look, why not? Let's start one of the GLP-1 agonists or tirzepatide to reduce his BMI. It'll help with his cardiovascular and renal risk, as I've told you, and reduce his HbA1c. And of course, if he does have heart failure with the HFpEF, there is trials coming through now with SGLT2 inhibitors helping that. And then we could even make a case for treating him with finerenone. He's a type 2 diabetic with albuminuria. Remember, that's 450 milligrams per gram, and to slow progression as well. So there's a lot to do. And of course, he needs to do something himself. Bless him, he's working hard. Give the rest of the family some time in the shop. Get out there and do some exercise, lose some weight. The GLP-1 agonists or Mounjaro will help him lose weight as well, but he must take an exercise. So basically, that's the holistic way of dealing with this guy. There's lots to do. It may be even that he might need some iron as well. I haven't even told you what his iron parameters are. That was the Iron Man study. Okay, so look, that's thank you very much for listening. I've given you a lot of information there. I hope it was worthwhile for you, and I believe that we're now going to have a panel expert discussion, aren't we? So I'm going to stop sharing and leave it to Professor Ray to take over. So thank you very much.
Oh, thank you, Philip. That was one of the most exhaustive and most interesting talks on this subject I have listened to. Thank you very much. I am sure that all the thousands of delegates who have joined have got enough to take home for tonight, but we have got very erudite and wise panelists with me. So we'll try to bring out some Indian perspective on this particular subject, on different issues. If you may permit, I go to Dr. Mona Chawla first. Hi, sir.
Yes, evening. Thank you, Dr. Ray, and wonderful listening to Dr. Kalra.
Yeah. So at the end, Dr. Kalra said at the end of the left lower corner of his slide that he would like to start either semaglutide or tirzepatide in that patient. Now, in your diabetic CKD patient in India with a metabolic syndrome, CKM patient, which one would you prefer, semaglutide or tirzepatide, and why?
Again, a great question. So one, a lot of differences in the Indian patients and the scenario. One, of course, a self-pay market and self-purchase power and so on. Now, currently, I think the evidence and the body of evidence post the flow trial lies with semaglutide, and hence, in the Indian scenario, between the two for now, also given the fact that there is a price difference between semaglutide and tirzepatide, my choice for the case, which was Anil, that Dr. Kalra showed, maybe to initiate semaglutide for this patient to offer the benefit. Of course, given the fact that he has diabetes, hypertension, would also want to give him the benefit of an SGLT2 inhibitor. So I strongly believe, like the subset shown there, that these patients are largely going to benefit with a combination of the GLP-1 and SGLT2 inhibitor. And where possible, I would want to offer the benefit of both these together. Both the drugs probably would work. Tirzepatide evidence in making, we will have it for sure. But as of now, my choice probably would be semaglutide for this patient.
Professor Kalra, between semaglutide and tirzepatide, which one for whom? Dr. Manachola gave a fantastic viewpoint from the Indian perspective, but from an universal perspective.
So now I think tirzepatide is more widely available in the UK than it used to be. I've got to say that. The cost issue really comes in when it's non-diabetic. So if we've got non-diabetic, metabolic syndrome patients with CKD, we're finding a restriction by NICE, and Body NICE, the National Institute of Clinical Excellence. They've recommended the drugs, but different parts of the country are using different criteria to start them because of the cost, because there'll be so many people who could benefit from them. So in Manchester, we would use either of the two in that patient. I have to say, I've personally put about 25, 30 people on semaglutide. I find that they prefer subcutaneous once weekly semaglutide to oral daily, just in terms of side effects and things, mainly nausea and other tummy, GI symptoms. But what I found with tirzepatide, and several of my colleagues on it, I've got to say, is that they seem to like it, and they find that they seem to have a greater weight loss with it and less side effects. But, I'm no expert on this, but it's just a small observation. So I would use both. But possibly, if I had to have it myself, and of course I go to the gym every day, then I would use tirzepatide personally.
So great. So Dr. Chawla, can we for the delegates have got a one-liner that if obesity is the predominant target, then it is tirzepatide. If it is cardiovascular and renal risk reduction in diabetes, then it is semaglutide. Maybe that is a simplification.
Yeah, I think that completely agree with that. So in terms of weight benefit, clearly tirzepatide seems to be outscoring semaglutide. But when it's going to be cardiovascular, renal, and for that matter, muscle, I think that kind semaglutide would probably score over tirzepatide as of now, till we have more evidence for that.
Excellent. So I go to Professor Manisha Shahai to change gear also. We are listening a lot about urinary albumin creatinine ratio. I see Professor Kalra also mentioned a lot. It is a relatively newer concept compared to creatinine and eGFR. What do you think is the pros and cons of treating patient on the basis of ACR? I mean, falsely high ACR. How do you encounter and how do you circumvent that thing?
Okay, thank you. Thank you. First of all, Dr. Kalra, wonderful lecture. So now coming to Sir's answer, I would say in India, till now, people are more aware of creatinine GFR, but Dr. Kalra has also brought out an important point that if you need to diagnose the CKM early, Indian CKM is different from Western CKM. It occurs at a younger age with a lower BMI. And the thing is, most of the times the GFR may be erroneous. Why? Because Indian muscle mass is quite low. The creatinine values are, and the patient may have an apparently preserved eGFR. And what happens in India is often more focuses on GFR and urine albumin is somehow not done. So first point is in India to identify CKM early, it's very important to do the urine albumin. Now coming to the question with which Dr. Ray asked, there are again fallacies doing an albumin. There are some problems and challenges of doing albumin in India. First thing is most of the government hospitals in India focus more on urine protein rather than the urine albumin. That's point number one. The second important thing is urine infections are quite common. Uncontrolled hyperglycemias are very common. Heart failure is very common, especially in CKD population, which we see with preserved ejection fraction. And again, because of many of these factors, the urine albumin may be erroneously high. So it's mandatory that when we are checking the urine albumin, we should do repeated samples. Shouldn't classify or define early stages of CKM based on a single value of albumin alone, we'll be misclassifying and mislabeling patients as a CKD or CKM when they don't have it. So always check it. Check it when there is no urine infection. In pregnancy, again, we know that's higher. If hyperglycemia is there, it's higher. In the presence of ketosis, it's higher. So rule out these conditions, do an albumin, and always repeat it and confirm that it is persistently high. So that's very important. Other important thing is point of care kits for albumin are available now for clinical use as well as in community use. But again, they are not available at the grassroots level. So many of the times we end up getting only a urine strip test done. That's what is available. But again, I would make the point that it's better to do even a dipstick if nothing else is available for the community level. And when you are in a tertiary care center, urine albumin definitely has to be done. Otherwise, as I said, Indian GFRs may look falsely normal. So there is a disconnect between urine albumin and GFR, especially in India. And mostly the GFR and albuminuria go parallel in the Western world, if I may say so. So I hope that answers your question.
Absolutely. Great, ma'am. Just it is my own query for enlightening me. We know that amlodipine can cause proteinuria. So is this protein albumin? Can amlodipine causes albuminuria?
So that's a very great question. And I presume part of it is albumin, because most of the guidelines say that if you are using amlodipine for controlling blood pressure, it's always wise to combine it with a RAS blocker. So we don't use it alone. So that's the reason it causes clinically significant proteinuria and albuminuria as well. Though studies like our own experience, we have been looking more at proteinuria with the amlodipine rather than the albuminuria. But the guidelines clearly state that in patients where you have any leakage of protein or albumin, it's always better to combine amlodipine with a RAS blocker. And that's the usual guideline directed practice.
Dr. Kalra, on this string, it is a very important issue. I didn't get a proper answer from many people. You are almost ready to start finerenone on the basis of ACR.
Yes.
And the patient is on albumin. Most of these patients are on albumin, on amlodipine. So do you give a trial to withdraw the amlodipine and see if the ACR goes to the normal range? Or would you start finerenone straight away?
Yes. So to be honest, it's really only coming in my practice in the last 3 to 6 months, the use of finerenone, the wide use. Again, it had to be approved by our main body, NICE, before we can use it. But it's a great question, this whole topic of amlodipine, because I presume it causes proteinuria by dilating the afferent arteriole and therefore driving hyperfiltration. So as Professor Sahay says, using using ACE inhibitors ARB concomitantly, hopefully would attenuate that. But so yeah, it's a great question, but I must admit I don't take notice of the fact that they might be on amlodipine. I'll have to start looking for that. So we are using it more in people who definitely have got higher levels of albuminuria, despite use of maximum dose ACE or ARB, and who are progressing. So that's when I'm bringing it in. Can I just make one or two other points? Because I loved what Professor Sahay.
Yes, please go ahead.
One was that we've got the same problem in the UK. Our secondary care laboratories in hospitals focus only on protein creatinine ratio because it's cheaper, right? That's the thing. So we've done that. So we're starting to use more and more ACR, but ACR is used in primary care in the GPs. If they send something to the lab, it's albumin. But I loved what you said about the creatinine generation from Southeast Asian people. And I, again, have started a lot more now to use cystatin C measured GFR, which was meant to come into widespread practice like 10 years ago and hasn't done. But I'm getting a lot of people referred actually the other way around who are heavily muscled. We've got more, you were saying it before, the work-life balance. We're getting more and more bodybuilders coming in who are taking creatine in the labs coming in with more muscle, and the GPs are sending to me with GFRs of 55 and saying they've got CKD. Well, if you do a cystatin C or a Cockcroft and Gold calculated GFR, they're coming in at 100 and not 56. So I know it works the other way. You could use cystatin C in a lower muscled population as well to get a truer GFR. So I think it's a really great topic, this eGFR. It's estimated, right? Yeah.
Yeah,
Before
absolutely,
going to
Dr. Kalra.
Yeah.
Yeah,
Dr.
sorry, sir,
Sahai,
can I yeah,
please.
sorry to interrupt. So yes, so
Please go ahead.
cystatin C is a very valid point, and in those people we are doing cystatin creatinine epiGFR if the people are able to afford it, because cystatin is not available for us in a government sector, and in primary care it's absolutely not there. It's sometimes difficult to get a creatinine done at primary care, so that's the problem we face. And other important thing is like about the thin fat Indian phenotype, that what happens is like central obesity is more prevalent, visceral obesity is there, and the CKM occurs with a lower BMI. In fact, the Indian cutoff for obesity is BMI of 25 and overweight is 23. So that's a bigger problem, and CKM occurs early, and generally what happens is again premature cardiovascular disease. In fact, people die because of cardiovascular disease before they progress to end-stage kidney disease needing dialysis. So the phenotype of Indian CKM is slightly different. And I think cystatin C would be a value addition, but again, the cost issue remains. So, but thank you for that explanation. Thank you.
Thank you.
I'm glad that my BMI is being calculated in the UK and not in India, because I'd be classic.
I have got just time for 2 quick questions. So I'll go to Dr. Chawla first. Sir, in your diabetic practice, a person has come with pure diabetes, early diabetes, no evidence of cardiovascular disease or renal disease so far. You have done everything. Would you still prefer SGLT2 inhibitor as a first line to prevent, not to treat, but to prevent the cardiovascular and CKD problem development as a primary prevention?
It would all depend on a few factors. It would depend on the patient's baseline HbA1c. It would depend on the patient's phenotype. It would depend on any other risk factors. Now, given the fact that an Indian patient or an Asian Indian is genetically more prone to develop cardiovascular disease at an earlier age, unless there are contraindications for me to use the drug, the larger choice today is going to be offered benefits of drugs which are going to give earlier cardiovascular renal protection. So the point that you're trying to hint towards, Dr. Ray, I would be inclined to using and offering benefit of an SGLT2 inhibitor to most of my patients with early diabetes today, unless their phenotype or the presence of any adverse events does not permit me to use that. The paradigm has changed, and which is where most of these patients would be and should be offered the benefit of these drugs, especially since we have them at a far more affordable generic price in India. I think many countries would want to do that probably, but they struggle. Their insurance and schemes not permitting for everyone. I think we are more blessed and should offer the benefit of the SGLT2 inhibitor. And in many cases, I would offer that even way before metformin to the patients.
Excellent. So simply putting nowadays, we should not ask why, but we should ask why not. Why not SGLT2?
Wonderfully said. Yeah, doctor. Absolutely. And
the last question perhaps to Dr. Sahai. Dr. Kalra, in his last case, increased the RB-Saturn to 300 and started finerenone. So how will you monitor this patient for potassium, where you are increasing the RAS blockade and giving finerenone at the same go? And what advice you will give to your patients to avoid hyperkalemia?
So wonderful and very practical question. So good thing is now guideline directed therapies, SGLT2 is also a part of the treatment, which Dr. Kalra introduced for his patient, and SGLT2 to some extent counteracts the hyperkalemia. So that's point number 1. But before that, I would advise our Indian patients specifically, because they eat a lot of coconut chutneys and all, they are a regular part of their diet. So focus on the diet. Now, the latest concept is don't be too scared of the potassium. I mean, in fact, the European guidelines are a little bit more liberal. We are scared of any potassium beyond 5.5, but we tell them about the diet, about reducing the chutneys and the juices, coconut water. So those things we definitely do. And now, so the first thing is the diet. The second thing, we also tell them about not using the low sodium salt, because many of them go purchase a low sodium salt which is very rich in potassium. So that's point number 2. The third point is we tell them to optimize the dose of RAS blockers, which often never happens in India because we are so terrified of the potassium that we use minuscule baby doses which are not nephroprotective. So that's the third point. The fourth point is you can give combination with thiazide diuretics, which again cause some potassium loss. But again, when you are adding SGLT2, they are smart diuretics. They cause potassium loss, they cause volume loss also. So many of the times you need to cut down on the thiazide diuretic, and SGLT2 does that action. And the fourth important point is now the guidelines, especially after the STOP ACE trial, have shown that the RAS blockers can be continued till a GFR of, stage 4 CKD, till 15 also you can continue RAS blockade, provided you take care of the hyperkalemia. So the main focus should be on changing the diet rather than and looking at other things. NSAIDs, for instance, they also cause hyperkalemia. The non-steroidal anti-inflammatory agents. So we should look at other causes of hyperkalemia, take a proper history. Some of the other drugs, commonly used drugs, cause hyperkalemia. So go through the whole list, focus on the food, then try to optimize the RAS blockade, add SGLT2, add a thiazide still if the potassium is higher. And then the good news is now you have newer potassium binders which were not available in India. For example, the sodium zirconium cyclosilicate. It's available in India by the name of Lokelma. The advantage over the previous potassium binder is that it can be used for a longer period of time, even for acute emergency situations also, and does not cause colonic necrosis. But again, it's expensive. That's an option, but should be the last option. So we should focus that for nephroprotection. All these therapies, which Dr. Kalra has so beautifully elucidated, should be a part of the prescription, but still the first part of prescription stays diet and lifestyle. So I would try to manage hyperkalemia like that.
Excellent. Like I was sitting in a classroom. Fantastic, madam. You're a real professor. Maybe just one would add to also to advise to avoid alternative medicines and unleveled homeopathic medicine. I am not against homeopathy, but unleveled medicine supplied in a from the doctor's chamber, I think it is a complete no-no. It can cause anything under the sun. Okay, so I think we have crossed our time, and I'm absolutely sure that everybody is going home today and their patients will be better from tomorrow. That is my anticipation and firm belief. So Dr. Kalra, do you have any final word for our Indian spectators?
Just to say, I have a strong bond with India. Thank you so much for making me so welcome, and some great discussion we've had afterwards. And no, it's an absolute pleasure as always to interact with you. So thank you so much.
So we'll want you more and more in our platform. So Dr. Chawla and Dr. Sahai, fantastic interaction, and the podium is back to Maheshji or Himangshuji, whoever.
Thank you, Dr. Ray. Thank you.
Permitted, can I just make one comment, sir? So, yeah, Dr. Ray, I just wanted to make one comment about your wonderful question that can we use these medications even before the stage of CKD? So there was a paper published, I think, in October 2025 about the concept of pre-CKD. So pre-CKD, that says that, see, we define CKD if the GFR is less than 60 or between 60 to 90 if there is proteinuria. So there was a concept. See, even 60 to 90 GFR is not normal. Normal GFR is about 90. So 60 to 90, these drugs are protective. Now you will ask whether there is evidence. So if we remember the trials which Dr. Kalra quoted, the DECLARE-TIMI, the other trials, the cardiovascular outcome trials. So in that paper, they have analyzed. So in the DECLARE-TIMI trial and the CANVAS trial and the EMPIRIC trial, which were primary cardiovascular outcome trials, the 50 to 70% patients did not have CKD. But in those group, they analyzed that group, non-CKD patients in those trials, the risk reduction was up to the tune of 50 to 60%. The hazard ratio was 0.5 or something. So we have evidence for their use even before the stage of CKD. So I like the concept, pre-CKD. We have pre-diabetes, we have pre-hypertension. Why don't we have pre-CKD? So that's the point I just
Similarly,
wanted
if you
to
use it in heart failure in non-diabetic
Yes.
patient, it prevents the first onset of diabetes. So I think we should,
Yeah.
as I said, why not rather than why should we use? So yes, Dr. Himangshu, Mr. Himangshu, please.
So it was absolutely wonderful dissemination of the topic, and today program contributes around 2,400 healthcare professionals across the country. I would like to thank our eminent speaker, Dr. Philip Kalra, Dr. Moderator, Dr. Soumitra Rai, and our panelists, Dr. Manoj Chawla and Dr. Manisha Sahai. Thank you very much for making this event a grand success. I also would like to extend my thanks to all the participants who joined from the different part of the country and has made program a memorable one. At last but not the least, would also like to extend my thanks to all the Lloyd field force who are working day in and day out to make this program a grand success. Thank you. Thank you very much, Doctor. Thank you very much, everyone.
Good night.
Thank you.
And have a nice weekend, sir.
Thank you, sir.